Balaji, here to present on comparative evaluation of visual acuity, quality of vision, patient satisfaction after implantation of extended macular vision intraocular lens versus standard monofocal intraocular lens in cases of age-related macular degeneration with senile cataract. I have no financial interest. Age-related macular degeneration is a chronic degenerative disease of the retinal pigment epithelium and the choroid. It currently accounts to about 8.7% of the blindness in the world, which is roughly around 196 million in 2020, and is expected to increase to 288 million in 2040. As we all know, there are two forms of age-related macular degeneration. The neovascular form leads to accumulation of subretinal fluid and choroidal neovascular membrane, which can leave a macular scar in the advanced stages. The same way, non-neovascular form starts as drusen, coalesces to form a geographical atrophy, and leaves a macular scar. In both the cases, the macular scar causes central scotoma, which can be often disturbing to these patients. When these patients develop senile cataract, the outcomes of cataract extraction in these cases depends on the disease activity, the size of the CNVM scar, and the geographical atrophy, which often causes central scotoma. These are actually managed using low vision aids, which can be external or internal. And the disadvantages of external devices are reduced field of vision. It requires a lot of motivation from the patient side and are cumbersome to use. Whereas the internal ones are either Galilean or Cassegrain telescope model, but they are complex designs which requires large incisions and leads to a lot of perioperative complications. Keeping this in mind, we aim to study the outcomes of extended macular vision intraocular lens, comparing it with standard monofocal lens like IQ. So ours was a prospective interventional study done in Dr. Rajendra Prasad Center for Ophthalmic Sciences, and we included a sample size of 20 eyes divided into two groups. One group, 10 eyes were implanted with extended macular vision intraocular lens, versus the other group was implanted with standard monofocal IQ intraocular lens. We aim to measure and compare the visual acuity, quality of vision, and patient satisfaction post extended macular vision intraocular lens, and compared it with standard monofocal lenses. And also we studied the effect of central scotoma using Goldman perimetry, and assess the safety profile of this particular lens. So we included intermediate dry age-related macular degenerative patients with senile cataract, stable neovascular AMD with central macular scar of less than 1 disc diopter, or a paracentral scar that spares the central macular area of at least 10 degree. And we included patients having Snellen's visual acuity of at least 660, and those who were willing to give voluntary informed consent to be a part of the study. We excluded unstable cases, those who required anti-VEGF injections, who had uncontrolled diabetic maculopathy, any other ocular and systemic comorbidities. So the results were, the baseline parameters were matched, comparable in both, and in visual acuity, the mean uncorrected and the best corrected distant as well as near visual acuity was comparable between the two groups. And we assess the quality of vision. We assess the mean higher order, total and internal higher order aberration at 3rd month follow-up, which was lesser in this IQ group compared to the extended macular vision intraocular lens, which was statistically significant with a p-value of 0.015. And also we compared the mean total and internal point spread function, which was comparable in both the groups. And the same with the FTF, but it was comparatively better in extended macular vision IOL group, but it was statistically insignificant. Patient satisfaction, we assessed National Eye Institute Visual Function Questionnaire, which had 13 questions clubbed under various subscales like general health, general vision, ocular pain, near activity, distance activity.
Please conclude, please conclude.
So the responses were found to be comparable. The safety profile, the limitation of the study was it was a pilot study with limited sample size of 10 patients. Cost-benefit ratio needs to be evaluated, and the efficacy of this in varying sizes of central macular scar patients need to be evaluated. So we conclude that there is significant reduction in the area of scotoma post-implantation of extended macular intraocular lens when compared to standard group, and it is safe as standard monofocal intraocular lens in cases of AMD with cataract.
Thank you. Do you have any question?
What was the name of the extended macular IOL which was used?
IOL AMD from Care Group, ma'am.
From?
Care Group.
Care Group.
AMD. The name itself is IOL AMD.
And
so
what all?
In your protocol. It's sorry, it's
Please
mentioned in your methodology.
Yes.
Is it mentioned?
Yes.
And what all investigation you do to find out the function of the macula?
Sir, I did a Goldman perimetry and we did a microperimetry also, and the scar size was assessed using Optos, and we included only patients who had a macular scar of less than 1 dis diopter. Larger scar patients who did not have a healthy macula, even in the more than 10 degree, we excluded them.
What do you mean by healthy?
So the delineation of the scar basically.
That will not tell you the function of the macula. The function of the macula will tell you if you do the ERG, the let's say multifocal ERG,
No,
the
sir, that was so.
pattern ERG.
Yes.
Okay, nice presentation.